We humans are a curious bunch. Let's put it that way. Anyway, what I was going to say is that
Oh, you were
I
going to
wouldn't
say
use
something?
a collective we on that one.
Oh, really? All right.
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest health study as I am by all the different recycling bins. Do you guys get as confused as I am? I see the different recycling bins. I know what I have in my hand, and I can't match it to any picture.
Just remember, blue equals sad.
I throw everything away because I can't figure out where to put it.
Well,
I do.
if you're looking for a way to cheer yourself up, you should check out this new website called the Population Health Exchange.
Oh, Chris, you are so ahead of me. We haven't introduced ourselves yet. That comes after
I'm Chris
the introduction.
Gill. That's Matt Fox, Don Thea.
That's me.
There we go. And
Happy
you guys are
2019
where?
again.
Where are you?
We're in Boston at the Godly Studios.
In the Godly Studio. And I am once again in sunny London. And that is not a joke. The past
Nor
2
is
days
it a
have been...
continent.
No, people got very upset about the fact that I referred to it as a continent. I apologize profusely. It is not a continent. I am very aware of that. Anyway.
You insulted a whole kingdom.
A continent is the kind of breakfast you get across the channel.
That is so right. Okay. So as Chris mentioned, you might want to check out the Population Health Exchange website, where you can find lifelong learning tools, programs, and classes, lots of good stuff. I'm not even going to try and plug it because Chris has already screwed me up.
Podcasts that get 5-star ratings mostly.
But what I would want to do is remind everyone, I do want to remind everyone to go ahead and rate us on iTunes or all your other podcast apps. Give us a rating, give us a review. We would very much appreciate it.
And if you do that, we'll give you a mug.
And we will?
Yeah. We'll send you a mug.
Everyone who gives a rating now gets a mug?
From now on, yes.
Oh, wow.
Wait a minute. Can we
Apparently-
follow through on this? Do we have resources? Do we have a
Apparently
budget?
Don's got some budget.
No, Nick is saying we don't got no budget.
Okay, well, how about this? You get a hearty thank you from us.
Yeah.
All right.
Not good enough.
So we do want to let you know a little bit of an update here. Don apparently has got the latest numbers, and apparently we've got 41,962 downloads.
From
We've
55 countries.
55 countries, 65 5-star ratings, and a bunch of reviews, which we are so pleased about. So thank you very
We
much.
love those reviews.
Yeah, keep them coming. We definitely appreciate it.
It's over 100 countries. Oh, wow.
Oh, wow. Over 100 countries. Wait a minute. How many countries are in the world? 182?
I think so.
I made that number up. 180
Something like
something.
that. That
Point
sounds
is,
right.
we need to hit those other 100 or those other 80 something.
Or is that the number of hours in a
We
week?
even got a download from the Russian Federation.
Just one?
I think it's just one, yeah.
All right. So anyway, let's get on to the show.
Yeah.
So today in our first segment, which is our Journal Club segment, we are going to look at a study which was investigating whether e-cigarettes are better than nicotine replacement therapy for quitting smoking. Then in the second part of the podcast, which is our deep dive, we're going to talk about when you can draw conclusions from so-called null results, null trials, or null studies. And then in our amusing segment, which is our third segment, we will get into some of the things that make us laugh out loud, or Don will explain to us what cat food tastes like, which we very much appreciate.
Or what to do with your Lego head.
Or what to do with your Lego head. There you go.
Not to do with it.
Yeah.
Or well, however you want to approach that. So in segment one, we are going to talk about an article that looked at using e-cigarettes compared to nicotine patches to help people quit smoking. It was done in the UK. The study was published in the New England Journal of Medicine, and it was entitled A Randomized Trial of E-Cigarettes versus Nicotine Replacement. The first author was Peter Hayek of Queen's Mary University of London, and Peter Hayek and colleagues. Now, of course, this is a topic that is hot in the news in general, e-cigarettes, and it certainly is a controversial topic. I don't know whether all the science is truly in on what we actually know about e-cigarettes, but that isn't really the point of this study. The point of this study is more to see whether e-cigarettes are more helpful than nicotine patches at helping you quit smoking. So let me get some of the headlines on this one. The New York Post says, vaping really can help you quit smoking, study finds. Business Insider says e-cigarettes could help adult smokers quit when paired with therapy, which I want to come back to that one. Vaping much better than smoking cessation aid than gum and patches, major study finds. That was CBS News. And then Time Magazine says e-cigarettes more effective than nicotine replacement in helping smokers quit, studies show.
Now, see, that is really saucy of them because it is not replacing
Saucy.
nicotine. It is another source of nicotine.
Yeah.
So what are they talking about? Did they read that paper?
Misleading.
I think I think that the headline before that was also quite misleading. I'll come back to that. So Don, can you start us off? Can you tell us what the study was all about?
Sure. So we all know smoking's bad. People definitely want to quit, and it's one of the hardest things to do. There, I think, was a major improvement in the tools that assist people in quitting when nicotine patches and lozenges and tablets became available, and there was a lot of interest in whether those actually were going to be successful in getting people to quit smoking. But some of the early studies that really looked at that didn't really find that to be the case, that they were really not that effective at getting people to stop smoking. And there was a Cochrane review, I think, that showed that pretty much all of the studies or in support of that. And in part because I think that the technology of these devices has changed over time. And what has recently become available are these e-cigarettes, or vaping in essence. And the more recent iterations of this allow you to dial up or dial down the amount of nicotine that is delivered. So they're a lot more sort of adaptable to individuals. So in any event, this group decided to do a head-to-head comparison of these new vaping devices against a nicotine replacement delivery device of their choice. So it was a two-group, pragmatic, multi-center, individually randomized controlled trial, which is a mouthful, as Matt said, which was done in the UK, which has a free stop smoking service as part of the National Health Service. Subjects were recruited at clinics, through advertisements, through social media. The inclusion criteria were a desire to stop smoking and not currently using either of these two kinds of devices. Exclusions were that people had to not be pregnant or breastfeeding. So at baseline, subjects would be asked to choose a quit date, a date where they wanted to quit smoking, which was usually about a week later. And then they were randomized to either the e-cigarette or the other nicotine replacement device. And they could choose whichever one they want, whether it was a patch or gum or lozenge or mouth spray, et cetera. Or they could use combinations. And they were given a 3-month supply of those things, which is typically $130 for every 3 months. And then the e-cig group were given refillable 30 ml bottles of nicotine extract. And they could choose the type of delivery device that they wanted. Everybody signed a commitment to not use the other group's method for at least 4 weeks. And they were then also counseled once a week for the first 4 weeks of the study. And that was sort of a unique aspect of this. They measured the exhaled carbon monoxide, which is a tell that you've actually been using cigarettes. And they measured it every time they came in for the first month after randomization. They had phone contact with people at 25 and 52 weeks. Their primary outcome was 1 year of sustained abstinence from cigarette smoking, which meant no more than 5 cigarettes from 2 weeks after the stop date, with carbon monoxide validation at the 1 year follow-up. And if people were lost to follow-up, they were considered to be not abstinent. Their secondary outcomes were abstinence from 26 to 52 weeks at 4 weeks, or 7-day abstinence at 4, 26, and 52 weeks. They also measured relapse rate and time to relapse. The other outcome measures were smoking status, expired carbon monoxide, and ratings of withdrawal symptoms.
I think
as well as
also
adverse reactions.
Also looked at severity of smoking-related symptoms like cough frequency and phlegm production and things like that.
Right. So there were a whole bunch of things that were measured and outlooks, but I mentioned to you what the primary and secondary outcomes were. So they had about 2,000 people screened, of whom about 1,000 attended the first session, and from that they randomized 886. So pretty equal groups, 430 in one and 447 in the other. And in the e-cigarette group, 81% of them made it to 12 months. And in the other group, 76 made it to 12 months in terms of follow-up. At baseline, from what I could tell, they looked basically balanced in terms of age, sex, whether they were employed, whether they were entitled to free prescriptions, median number of cigarettes typically smoked, expired carbon monoxide at baseline, past use of supplements, and e-cigarettes. So as far as the primary outcome was concerned, at 12 months, total abstinence for the group that was using e-cigarettes was 18%. And in the other group, it was 9.9%, or an 8.1% point difference. The number needed to...
Absolute or relative?
I think it was absolute.
That's an absolute difference, yeah.
Yeah, absolute difference of 8.1%. That calculated to the number needed to treat for one successful abstinence would be 12. So you would need to have 12 people go through this program in order to expect that there would be one person who would successfully be abstinent at 12 months. Among one-year abstinence, 80% were using e-cigarettes versus 9% were using the other nicotine replacement mode. As far as secondary outcomes were concerned, abstinence at all levels, at all the intervals that I mentioned, were better with e-cigarettes. And they did a series of sensitivity analyses with various protocol deviations, and didn't seem to have any effect on the outcome. The e-cigarettes remained the better choice, and the relapse rate and time to relapse did not differ by groups. So I think there was minor differences in safety. Is there anything else that I'm missing?
No, it's pretty effective.
Yeah, it was pretty effective.
Well, so I would certainly agree. I mean, it was more effective than the standard options that were available to people. Although
18% is not all that effective.
18%. I mean, cigarettes are hard to quit, and we've seen this before, right? We looked at a previous smoking cessation trial, and everything that has been tried, even when it's an improvement over what's previously been done, the quit rates are always pretty low. Mm-hmm. This is not easy.
Yep. No, and it's interesting just in terms of the debate that you had referred to previously, Matt, because if you were going to make e-cigarettes available for this particular purpose, you have to worry about e-cigarettes being made available to people who are not currently smoking as a gateway drug. So on balance, from a population basis, it in fact may not be good to go this route if you're only having that relatively small incremental benefit in this very specialized population.
Yeah, that's a really good point.
Chris, what's your take on this study?
Well, I wanted to actually, that was the thing I'd circled on my list of things to talk about, and I wanted to go at that first. Is that we are not talking about whether e-cigarettes are benign. We're talking about whether they're an effective smoke. I'm not even going to say smoking cessation aid so much as a nicotine replacement strategy. One of the things that was really interesting in their data, and I was curious whether either of you had noticed this, that at the end they talk about whether people were still, had what the total abstinence rate was relative to the use of the nicotine replacement strategy. Mm-hmm. And so they had 18% was the final quit rate, or mm-hmm. the abstinence rate at 52 weeks, mm-hmm. which we should also note may be a little bit optimistic because it's based on a reported abstinence plus the carbon monoxide reading. But the carbon monoxide only tells you about the last 24 hours or
right.
so. And so, this is equivalent to, the dental floss conundrum. Whereas when you're going to go to the dentist to get your teeth cleaned, they're going to ask you about dental floss and you haven't been flossing. So the day before you floss so that you can say with a straight face that, yeah, I floss.
I'm pretty sure they can still
you
tell.
Do that, Chris.
Yeah, I don't think I'm the only one, actually.
I think you are.
Feeling that this is a pretty common dodge. Yeah. There's another equivalent, which is going to the exercise, to go to the gym, and you get on the eucalyptus, the elliptical.
The eucalyptus?
The elliptical machine.
The eucalyptus machine.
The minty machine that the koalas ride, so they say trim.
Yeah. No, it's great. It's fantastic.
Anyway, it always asks you to put in your weight, and I always lie to it. And I'm like, why am I lying to a computer? It doesn't care. So it's a self-report. We humans are a curious bunch. Let's put it that way. Anyway, what I was going to say is that
you were going to say something?
Collective we on that one.
Oh, really? All right. I'm going to get a private eye to follow you around and see how you're. All right. Anyway, he's quieting down now. So anyway, the point I was trying to make is that 18% of people reported that they quit, which may be, maybe a little bit of an overestimate, but 40% were using their e-cigarettes, right? So their e-cigarette use rate was double the rate of quitting. Okay, but the quitting rate meant that actually 80% of the people were still smoking. So if you do the math, that means a lot of people must therefore have been smoking and still using the e-cigs, right? Whereas the number was 4% for who had quoted quit, but a lot of them were still using their, not so many, but their nicotine replacement patches. They were much less popular. And so we have to assume that there's a huge number of people who are now smoking and vaping, not just, so it's an improvement, but we are still a long way away from the population level nirvana of no smoking.
Oh, totally. Matt, are vape shops popping up all over the place in London where they did this study?
Absolutely.
I mean, that's got to have an input
I don't know if they're popping up,
this.
but they're everywhere.
Yeah, they're everywhere here too.
I don't visit them, but I see them.
Now, with all of that said, I still thought the study was really quite well done.
Oh,
I thought it was solid.
And
Well
I was
done.
impressed with it, and I was persuaded that this is a better strategy, and that if we're talking about harm reduction, this seems like a reasonable way to go, and it has obvious parallels with how we think about methadone. Right? That the goal of methadone is not to get people to not take opiates. The goal is to have people use opiates in a safer way that's not going to lead to a fatal overdose. And here we're saying we're not really, we're hoping that they will quit, but we're also just saying, inhaling nicotine vapors without tar and all those, the stuff that's in the particulates that are in tobacco smoke, that is probably, we assume, but though I guess the jury is still somewhat out on this, but probably safer and healthier for you than cigarettes because it doesn't involve
do we know
burning
that?
things.
But I think it's important.
Do we know that?
Well, we know that the carbon monoxide is bad, and we know that cigarette tar is bad. So we're emitting a lot of things. What we don't really know is that nicotine intrinsically, how safe is that? I think.
Well, we
I
don't know.
Let me read you a list of the nicotine health risks. So these are the risks associated specifically with nicotine, not necessarily delivered through a cigarette vehicle, but it's blood clots, atherosclerosis, disturbed sleep, diarrhea, heartburn, arrhythmias, high blood pressure, stroke. And in pregnancy, there's child obesity, high blood pressure, type 2 diabetes, respiratory difficulties, infertility. Other effects include pneumonia, tremors, pain in the muscles, insulin resistance. So it's not a benign drug.
Right.
No, fair enough. But do we know all the chemicals that can potentially be put into e-cigarettes and what the implications of those
It's
are?
not just pure nicotine.
Sure, that's another good point. It's a little bit the wild west there.
When I read this study, kudos to these authors. I think they did a very nice job. I think there's some things I could quibble about, like is there potential contamination, I guess is the word you'd use for it, a crossover, that you have some people in the, you can buy any of these products over the counter. Right. And so you may have some people, in fact, we know there were some people who were in the non-e-cig group that used the e-cigs.
But they all signed commitment not to use the device in the other arm.
Yep. And
they promised.
Isn't that good enough?
Signing that means as much as Chris putting his weight into the exercise machine, apparently, or telling you that he flossed.
152 pounds.
But one of the things that I did think about when I was reading this is that, is this the right outcome? Is quit the only thing that would help us make the decision around whether to say this is the intervention? Clearly, it is preferable in terms of helping people quit smoking.
I suspect you're asking a rhetorical question, Matt.
Why?
I have my antenna have gone up.
Okay.
So I'm going to give you a non-rhetorical answer, which is, I think, what you're hoping for. Which is, I was surprised that they didn't look at the total cigarette consumption as a sort of a non-binary continuous variable instead. I was curious about that.
It's as physicians, it's a piece of information that we collect in a semi-quantitative way. We ask how many packs per day have you smoked for how long. So,
and of course, we know they lie to us when they give us that answer.
Right. In terms of the amount of alcohol that they drink. But we know that there is a dose response effect with respect to cigarette smoke.
And so if we're going back to that funny dichotomy in the data where 40% were presumably, 40% were using these replacement devices, but only 20% had quit, meaning that at least 20% were still smoking while they were using the replacement device, if my logic is correct here, one would still wonder if perhaps they had reduced their cigarette consumption substantially. And so in some ways, it might actually underestimate the benefit of this
harm reduction.
On a harm reduction scale.
Yeah, I suppose I wasn't actually going in that direction specifically. More what I was thinking was, if it's true, we don't know what the true harmful effects of e-cigarettes are, then wouldn't a better outcome be a more long-term outcome that was something that told us about the health benefits of using e-cigarettes to quit?
So you mean follow them for another 20 years and count the number of cases of cancer?
Yeah, isn't that ultimately where you want to go with this?
Yeah, but is that a doable study?
Well, I don't think it's going to take 20 years, but it is a doable study. Yeah, I'm not arguing. Again, I'm not arguing that is the only thing you'd care about. I'm just saying I'm not. I don't know the literature well enough to know, but I don't know whether or not we really know the long-term effects of e-cigarettes yet, and therefore it just seems like we'd want to know a bit more.
Yeah,
the
absolutely.
other thing that this made me think about, which is something we really haven't talked about much, is that when we talk about effects, we're talking about averages, population averages. So on average, 18% quit in one group, which was the e-cigarette group, and on average 9.9% quit in the nicotine replacement group. But these interventions are not the effects that they have on individuals can be counterintuitive. So it's theoretically possible that there are people who were in the e-cigarette group and didn't quit, but if they had been in the gum group, might have quit. So there may actually be some people for whom being randomized to the e-cigarette group was a negative for them. And I mean it's a little hard to imagine, but I mean the way I always think about this is self-driving cars are becoming soon a reality, and we could get to the point at which we could reduce traffic accidents by some massive number, but there will also be some people who will die in car accidents specifically because they used a self-driving vehicle. Yeah. And that's on average, if there's a net benefit, then we think that's good. But there will be people who will be negatively affected by these interventions as well. So it's just something that I constantly remind myself about.
You can say the same thing about every single medicine on the market.
Absolutely. No. I mean, with really just about anything. I mean,
except for Prevagen.
Exercise and heart attacks. I mean, it prevents heart attacks for some people. It will cause heart attacks for others. So there's a whole long list of things.
So what we came out of this was a new fact, or a confirmation of a strongly held opinion that e-cigarettes are probably a pretty good way of substituting tobacco for something that will be more acceptable to people who are addicted to nicotine.
Yeah, so can I ask a question? So I want to go back. So I said to you that I found one of the headlines kind of strange. You found a different one strange. But the one I found strange was e-cigarettes could help adult smokers when paired with therapy. And it's the when paired with therapy part that I found interesting. Was your interpretation that you had to have therapy?
No. This was one of those enhanced control strategies where both sides got counseled as like a standard of care.
So that's the issue.
So there was no when enhanced because we have no information about that. That was not part of the experiment.
I think the difference was that this was one of the first, if not the first experiment to actually use counseling. And that was one of the criticisms that came out in the Cochrane review, that the previous studies looking at nicotine replacement wasn't associated with counseling. And that was one of the advantages that I think the authors put forward.
Right, but both groups in this case got the counseling.
Yeah, I'm not disagreeing with you, Matt. Yeah.
We're not looking at the effects of the counseling. Correct. The counseling washes out. It doesn't mean that the counseling couldn't have had an effect. It's just that we can't see that in this study.
Yeah.
So when they say when paired with therapy, I think they're getting at the fact that both arms were paired with therapy, and therefore you would interpret that as needing the therapy. But we actually don't know whether therapy did anything or nothing.
It's not part of the experiment.
It was technically correct what they said, but intensely misleading.
I mean, it was. I suspect it was a misinterpretation on their part.
Yeah.
The other thing I did want to point out was that there was about 23% loss to follow up in this study. And you had about 20% of those assigned to nicotine replacement started using e-cigarettes. So this was not, this is not your cleanest of comparisons, which is fine. I mean, this is real world.
It's pragmatic.
Or closer to real world. And so I'm okay with that. But I think we're not looking at the pure effects of, well, I shouldn't say that. The crossover is probably fine in terms of real world. The loss to follow-up is still a problem.
Mm-hmm. I agree. Yeah. I sort of wonder in a kind of slightly cynical and snarky way how many pragmatic trials we're going to have to review before we roll our eyes when we see the word pragmatic.
Yeah, that's fair.
That wasn't snarky at all.
It was snarky, and it is starting to like enter into the lexicon of what all trials must claim to be in order to be taken seriously. So they have to be pragmatic, and I'm going to start pushing back, I think.
All right.
I would like to do a study of study designs trials. And to see how many claim to be pragmatic that are fundamentally different from trials that didn't bother to call themselves pragmatic, and whether the word pragmatic actually means anything after a while, or if it's just like the new word.
I would like to see an unpragmatic trial.
Yes.
There we go.
Like a trial that was done by volunteers while using stilts.
While juggling. Yep, there you go. Yep, there you go.
I'd like to see that one.
Any other last points before I take the last word?
Stilts versus no stilts on the 100-meter dash.
Backwards.
We want to know.
Okay. So last word. I thought that the title of this study told me just about everything I needed to know except one really critical piece of information, which was the outcome. A randomized trial of e-cigarettes versus nicotine replacement therapy.
On what?
To prevent losing my car keys?
On stilt use?
I don't think it takes a whole lot of inference.
Well, it could have been cancer. It could have been emphysema.
Exactly, it could have been cancer.
Wheezing. He's right. They
could have been a lot of
like to keep
different
these things
things.
very pithy, but I think this was a little bit pity. It's a pity it was so pithy.
Yes. Once again, 150 word introduction. I am clearly writing my papers wrong. And then my favorite line or favorite piece of information from this entire study, they say that in their methods that they used a pseudo-random number generator instead of software.
Wow, that
which
is very
seemed
technically correct.
That seemed very precise. Very precise.
Well, let's see how short we can get our intros down. We could be like, disease bad. Problem not solved. Therefore, ask question.
Study done.
It was 2 paragraphs. It was.
Yeah.
Get it down to 6
No,
words.
I think this was the shortest one we've ever seen.
I think most of us are used to writing 3-paragraph introductions. 2
Oh yeah,
is
you have to have
outlandish.
3 paragraphs. 3 paragraphs, 500 words. That is always my target. This was 150. I'm impressed. All right, let's
pragmatic.
move on.
Yeah, when does terse become a curse?
Let's move on. So let's get to our second segment where we want to talk about so-called null trials. And I'm trying very hard not to refer to these as negative trials, which is what people will often refer to these as. Essentially a trial which came to often a study that came to a non-statistically significant finding, although I would say a study that came to the conclusion that there was no effect of the exposure on the outcome. And this came up because we were batting around a study that we were thinking about doing on the podcast for segment 1. And we kind of nixed it because we basically said, well, they didn't really find anything. It was a null trial. And I am strongly of the view that null findings are important findings, right? If you tell me that ice cream doesn't cause cancer, and we are confident that ice cream doesn't cause cancer, that's really important information because then I can go out and eat the ice cream. And I'm sure ice cream has no other negative impacts, so we will just stop right there. But the question becomes, when you look at studies that don't find an effect, how do you make the transition from saying something didn't find an effect to saying, I am confident there is no effect? What's your Don? What's your take on that?
You have to. I was just going to say that we have to distinguish, because I think it can be a little bit confusing. We have to distinguish between studies that are looking for superiority studies, in essence, and not equivalent studies, because equivalent studies are designed to find no difference, and when they find no difference, they are successful.
Yeah, so superiority studies, meaning we're looking for an effect. Equivalency studies that are specifically designed, or non-inferiority trials, studies that are specifically designed with the idea that there probably is no improvement in mind, but we would be just as happy with an alternative that was equivalent.
Right.
Okay, sorry. So go ahead.
So the question is, what in my thinking is the benefit of those, or is what?
Well,
the question, counselor.
So I think what you were getting at with the equivalency trials is those studies are designed to specifically answer a null question.
Right. And so for this discussion, we have to exclude those from consideration because they're null. Well, not null. They're finding no difference.
Well,
yeah. Although you could have an equivalency trial that didn't find equivalence.
That found superiority.
As you well know.
As I well know. As we both know.
Those are the best kinds of studies.
We have certainly done that.
Yes. And taught it every year.
You think two things are going to be equivalent and they're not.
Can we read into the record what the trial was? Because I bet people are kind of curious now.
It was a trial of stilts.
It wasn't.
This is a trial that both Don and I were involved in that looked at community-based treatment for severe pneumonia.
No, we're talking about the trial that got us talking about today, about the in vitro fertilization.
Oh, you're talking about the trial that set us off, which was
the null trial.
A study by Sarah Lenson. It was a randomized trial of endometrial scratching before in vitro fertilization, and they didn't find a benefit.
Right, and specifically, they found that the relative risk, they were looking to see if endometrial scratching would increase fertility rates with IVF, and they found nothing.
Yeah.
But their relative risk between the two groups was 1.00, with a confidence interval that went from 0.78 to 1.27. So it was it was like point estimate, no difference, and a pretty tight confidence interval around that no difference.
Is that a tight confidence interval?
It could be tighter, of course, but this is,
Certainly,
I guess it's
no
up to-
disputing the point estimate.
right.
No,
I guess the rest
that's
is
a
more
pretty.
It's up to the eye of the beholder.
That is pretty spot on.
Yeah, that's pretty spot on.
As far as the point estimate goes. But but that's really what I'm getting at here, which is I think obviously you got to look at two things. You got to look at where's the point estimate, how close to the null is it? And I bring this up because you may remember in one of the previous episodes, a couple back, we looked at a study that was looking at peanut sensitization.
Yeah.
Desensitization. And they did the study. Most of their study were under 14-year-olds, I think, or under 18-year-olds. I can't remember. But they did include some 15 to 45-year-olds.
Yeah.
And they drew the conclusion that there was no effect in the older population.
We were all annoyed
when
by
in
this.
fact,
Yeah.
when in fact they found an effect, they just were underpowered to be able to detect it statistically. And so they drew the conclusion there was no effect. And I would say that is the exact opposite. That is when you don't want to say there's no effect. You want to say actually the data are most consistent with an effect. We just didn't have, we need more data. And so that's what I'm trying to get at. Where is your comfort zone with saying, I believe this is truly a null finding?
Yeah, well, let's take this IVF paper as sort of a test case. So, the confidence interval tells us that statistically we could be looking at the papal scratching of the endometrium could make it harder to get pregnant or could make it slightly easier to get pregnant. But the most likely explanation, interpretation is that it has no effect either way. But the confidence interval allows for us to say that there's the potential for a slight benefit or a slight harm due to this on whether you can get pregnant or not. And so if one was like a funding agency trying to decide where to put one's money, and you had done this question because it's a very legitimate question, and you get this result, would the fact that the confidence interval, includes the potential for slight benefit or slight, harm, would that be enough to sink another $1 million into trying to answer this question? Or would you say effectively this study has said the answer seems to be no, let's move on? Like that to me is one sort
that's
of
the question.
pragmatic way to go here. Right?
Yeah. And so with this one, do you have enough information?
I don't know. I mean, it was 1,378, and like you said, the width of the how precise do you want to be? It's a value judgment.
I mean, I think you have to make that judgment based on the power of the study, and oftentimes in situations like this, the authors will present what the power calculations are, so you have a precise quantitative assessment of how likely it would be for you to actually be able to find a difference given these numbers.
Yeah, I mean, I think the confidence interval tells you much more than power. They are intimately related, but I think the confidence interval tells you. But Chris, the reason I ask you, is this precise enough? Is I personally struggle to say when I think a confidence interval is narrow enough to conclude that something is null when I'm looking on the relative scale. Mm-hmm. Because I don't exactly know what the relative measures mean in this case, because I don't know what the baseline values are. Whereas if you convert these to absolutes, absolute differences, and put a confidence
Much
interval
more
on
useful.
that, then I'm better at saying, okay, minus 5%, plus 5%, okay, I'll be willing to accept that. I can often make that judgment. Whereas when you tell me it's 0.8 to 1.27 or whatever you said it was, I don't know if that's precise enough.
The absolute values there to the record, because they are also they add to this debate. And so the frequency the end point for the study was whether the women who underwent this scratching technique were able to deliver a live-born baby versus not. And in the group who received the endometrial scratch therapy, 26.1% became pregnant. In the group that did not, 26.1% became pregnant. It is
pretty much what you would
pretty
expect
exact.
from the point
hard to
estimate.
say that there was a difference there.
Yeah. Okay, now, but then if you look at the confidence interval, so you're saying the upper limit was 1.27, you said?
Yeah, and lower was 0.78.
So a 25% increase or decrease off of a 20% absolute rate, what's that, a 5% change? I don't know. That's why I'm saying the knowing the values helps. Getting the absolute difference helps. But I want a confidence interval around that to be able to judge whether or not I think it is precisely null.
Right.
I mean, it is, right? It is in this case. I'm pretty sure we can conclude that. In other cases, it's not exactly because, what if it's the risk ratio is 1.0, what was 1.1? In some cases, 1.1 is meaningless. In some cases, 1.1 is
a big deal.
Is a big deal. And so it's context specific. It's baseline value specific. I'm just saying this is not always easy. And so if you put it on the absolute scale, I find it much easier.
I think also talking about this subject with respect to the findings in an individual null study is important, but also begs the issue of publication bias. And that studies, I mean, this appeared, was it the New England Journal?
Yeah.
This appeared in the New England Journal because obviously the editors felt like it was an important enough statement, but that's not the norm. And a lot of times a paper with a null finding is harder to get published. And we've talked about this in some of the other podcasts, but I think it's really, really important that if it's done well and it's done properly and it addresses a question of public health relevance, that they get published as prominently and as frequently as the non-null findings, because otherwise you're missing information. You're going to be inefficiently reproducing these kinds of investigations, and it's going to be a waste of money and potential harm on people.
Mm-hmm. Yeah, precisely null findings are important, and clearly there are null findings that people find important and interesting enough to publish in the New England Journal. So I don't want to say that they are never, but I do agree with you. They're certainly harder to get published, and you will struggle more. Mm-hmm. So the only thing I want to add to this is so clearly we're all kind of in the camp of the confidence interval is kind of where it's at it's the point estimate and the confidence interval in terms of trying to decide whether or not we are truly looking at a null finding. Where that can break down a bit though is when you have bias in your study. Mm-hmm. So if you have a really, really big study and you find a null finding and you've got a really, really narrow confidence interval around it, but your result is biased, then you have, extreme confidence in the wrong answer. Right. And that I think can be quite dangerous, which is why I advocate for trying to quantify systematic error. But I think the point there is and there are so many exceptions to the rule, but if on average non-differential misclassification biases towards the null when you have a dichotomous exposure and outcome, that's going to push you towards the null. If you've got large numbers, you could have a very precise null that is wrong null. Mm-hmm. And I think that's where the danger lies.
Yeah, totally agree.
Yep. Something to keep in mind, too, as we continue to go into the era of big data.
Absolutely. All right. Any last words before we move on to
all about the p-value, man.
Stop it. You're only doing that because I'm not in the studio and can't reach over and hit you. Yeah.
You'll be happy to know, Matt, that my latest mantra in peer reviews is when they give the point estimate and the constant interval and the p-value, that I write back vociferously demanding that they remove all the p-values.
Thank you, Chris. That makes me so happy.
Why would they include both?
They do it all the time.
They do it all the time. People do it all the time.
Like, it seems, and I'm totally persuaded by you, Matt. Eventually, you got to me that it is in fact adding no useful information. We should just stop it.
We are your peons. And that's just
terrible.
The letter P. That's not the word P.
Right.
Okay.
Indeed.
Well, let's move on. Let's definitely move on from that.
All right, you go first, Matt.
So let's go to our final segment, which is our amazing,
or wild and wacky,
and amusing. It is not wild and wacky. It's not interesting and amusing. How long have we been doing this? And you cannot say it right.
Sessions.
42. This is 42.
All right. Well, let's hear it.
So we want to. Well, no. First, I have to do my intro, where we want to highlight some of the weird, wacky things that happen in our field, or Chris will read us the entire edition of PNAS.
No, not this week.
Oh, okay.
This week it's science.
All right, so I'm going to go first. When you create your syllabus for your course, you have to put in one of these academic integrity statements these days. Chris, you have one of those for your course?
This is like the plagiarism thing?
Yep.
Yeah, if you
Thou
if you
shalt
cheat,
not plagiarize?
something like that. You got to say something. So I found this online. I think I was pointed to this by Twitter. I cannot confirm that this was actually used in an actual syllabus, although the syllabus itself is online on an intro to philosophy course at Ohio State University for Philosophy 1100. So whether or not it's real or not, I cannot say. But this particular professor's, if it's real, academic integrity statement reads as follows. I have absolutely no tolerance for cheating in any form. Students who are caught cheating will be given the strongest possible consequences allowed by the university. Students who cheat and are not caught will be haunted by the memory of their misdeeds for the rest of their miserable lives.
Wow.
Guilt
There
trip.
you go.
I like
There
that.
you go. And you just leave it at that.
You would
know?
think that would be the kind of thing that they would put in a psychology syllabus as opposed
Yeah,
to a
good
philosophy syllabus.
Good point. Although, there's probably some moral issues and philosophical stuff
this
as
is
well.
true.
But yeah, good point.
Can I
All
go
right.
next?
Yep.
Or Don, do you have something funny to say? Because mine is not funny. Mine is esoteric.
I think I do, yeah. I have so many to choose from. So apparently, did you guys know that there are some animals that are super sensitive to the magnetosphere?
Yes, birds.
Birds,
For example.
we think, and maybe shark, we think.
Sharks?
Sharks?
Great white sharks. I heard this.
Yeah, possibly. Did you know that the same thing is true of dogs?
Dogs.
I didn't know.
Yeah.
Nope.
So there's this is a paper that appeared in the Frontiers in Zoology by Vlastimil Hart and others from the Czech University of Life Sciences. And what these individuals did was to measure the direction of the body axis in 70 dogs, 37 breeds, 1,893 observations while the dogs were defecating in a public park. And they also made 5,582 observations for while the dogs were urinating in a public park.
Where did they put the petri dishes?
They didn't do it use petri dishes. It was simply an observational study. And what they did was they looked at what the
It
orientation
was an observational study. I hope it wasn't more than that.
There was no intervention plan.
No data collection
So
beyond.
what they did was they observed the north-south orientation or the axial orientation of the dog while they defecated and while they urinated, and they determined that during period, and I didn't know this, but apparently the magnetosphere is very dynamic, and there are periods when the magnetosphere is quiet and periods when it is not quiet. And they were able to get that very specific information for that park and correlate that when the magnetosphere is very quiet, the dogs tended, while defecating, to line up in a north-south orientation. However,
Why?
they found it was true with female dogs defecating, male dogs defecating, female dogs urinating, but male dogs, while they were urinating, there was no correlation.
Because they're all over the place.
But because there's another purpose for a dog urinating besides just voiding itself.
Right.
Huh.
Right. Interesting.
So
Why? Wait, but why?
The next time you take your dog out,
Check which
Take
direction
your
he's lined
compass
up.
also.
And I saw
You
in
have
the
a
newspaper
compass
the
on
other
your
day that the
iPhone, so there you
magnetosphere
go.
is shifting. Not the magnetosphere, but the true.
Well, that's what
the magnetic north.
That is what
shifting.
That is what they measured. That was what was stable and unstable. So there are shifts over a long period of time, but there are also minute by minute fluctuations.
Wow.
And so dogs like to defecate north south when it's a time of a quiet magnetosphere.
That is cosmic.
But wait, sorry, but wait,
Why? What? Say what?
why? I still don't get why.
Why did they do this?
Yeah, why do they line up? Because it
Somehow dogs are sensitive to the orientation of the magnetic field, and they feel more comfortable or more at home when they're pointing north while their butt is pointing south.
I bet it's got to do with quarks.
There you go. All right, Chris, what do you got for us?
Well, you're right. Nothing can compare with that. But I'm going to talk about a paper that I found in Science by lead author Michael Mina and colleagues. And this is actually from a couple years ago. This is 2015. And this is about long-term measles-induced immunomodulation.
Oh, I read that paper.
This is a really interesting paper.
That's a very cool paper.
This is a very cool paper. And so their paper was quite complex, and I'm going to try to reduce it to make it less complex. But what we know is that historically measles killed millions of people, millions of kids mainly every year, and that even now measles kills maybe a couple 100,000 kids on the planet every year.
And this is a very topical issue right now.
This is a very topical issue because, of course, we're having measles outbreaks all over the Pacific Northwest right now, and California.
And Europe.
And in Europe. So it's like measles is back. I'm not going to get out of editorial, but measles is back, and obviously it's because of declining vaccination rates. Now, with the introduction of the measles vaccine, a very curious thing happened, which is that measles mortality went down. And that was not surprising at all because you would expect that. That's what the measles vaccine should do. But interestingly, all-cause childhood mortality also went down in the aftermath of introduction of measles vaccines. And, this has been noted for decades. The WHO has endorsed it in its official statements, but no one is really exactly sure why this happens. Or really how to quantify it. Now, in the lab, there are some clues because if you you infect a macaque with measles and look at its immune function, you'll see that the measles infections leads to a total body depletion of lymphocytes, which are some of the main white cells that fight infections. And also it has hits on changes on the innate immune system as well. And so there are all sorts of immunologic changes, but these have always been assumed to be fairly transient, and we're not really sure about the magnitude of these effects. And so what they did in sort of a population modeling study is to look at the introduction of measles vaccine in the UK and in England and Wales, in the United States, and in Denmark. And in each of these locations, the measles vaccine was introduced at different points in time. So like in Denmark, this happened pretty recently. It was like in 1982 or something, which I was surprised to learn about. I didn't know it was so recent. Whereas in the United States and the United Kingdom, it was back in the 50s. And so what you see is with the introduction of the measles vaccine that these utterly profound drops in non-measles associated infectious disease deaths in children. And so the question is this because the measles vaccine is augmenting immunity? And that's why it's sort of a non-specific way. So it's not just measles, but it boosts your immunity. Or is it because the measles infection that is being prevented by the measles vaccine leads to immunodeficiency? And it appears to be the latter based on these monkey studies. And so they were able to sort of do these interesting sort of computational analyses at whole population levels looking at the effect of this. And they found that the impact of measles, like a measles infection in a child, under the age of 5, registers as an increased absolute risk of mortality due to things like pneumococcal pneumonia and meningitis and diarrhea. And that effect lasts for about 3 years, which is astonishing.
I know, and profoundly important, especially
so
now,
important.
because of all the anti-vaxxers and all the people that are vaccine hesitant.
Absolutely right.
Because it's not just measles that could kill your kid.
Right, and the measles vaccine turns out to have a double win. And kind of an interesting thing about this, their analysis, I thought made it a little more robust, because these are all observational data, of course. It's not an experiment, was that they also looked to see what was the impact of the introduction of the pertussis vaccine. And, to see, is this a health-seeking behavior associated with the kinds of people who get measles vaccines versus the vaccine per se? And then they found with the pertussis that you see a drop in pertussis-specific mortality, but there is no spillover effect to other infectious diseases. It is just measles.
Yeah, that was a very cool
paper. It was such an interesting paper. And I encourage the listeners to go out and read it. It's a bit dense.
Cite it again.
It is Milne and colleagues in the journal Science in 2015. So great paper.
MILNA?
MILNA, yeah.
Okay.
Very cool. All right. Well, that is the end of our
You've
program.
wasted another hour.
Got any feedback or this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at @PopHealthyX, or you can tweet me at @ProfMattFox, or Chris at @ID.Gill, or Don at @DTheo1. And you can find us on the Population Health Exchange website at www.pophealthyx.org. We want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.